Myself, Dr. JIBRAN presents to you Simply Pathology, and today we are back with a very important session. Today we are going to continue the rapid revision exam slide series number 5. So let us begin without wasting any time, the case number 46. So case number 46, basically there's a 62-year male presenting with nasal obstruction. So what do you see over here? You can see a non-invasive tumor predominantly growing in an endophytic pattern, okay, comprising of nest and ribbons of immature squamous epithelium. Okay, if you see, the nests are basically rounded and they are defined or limited by basement membrane. As you can appreciate over here, certain transmigrating, okay, neutrophils are present, and you can also see the presence of mucinous cells as well. So what is the diagnosis? Very easy. It is a case of sinonasal papilloma inverted variety. Okay, so section shows a non-invasive tumor growing predominantly in an endophytic pattern comprising of nest and or ribbons of hyperplastic immature squamous epithelium within edematous hypocellular stroma. Yes, the stroma, as you can appreciate, it is edematous and hypocellular. The nest, they are rounded with an intact basement membrane, and very importantly, you can see the prominent transmigrating, okay, neutrophilic inflammation. Scattered admixed ciliated or mucous columnar cells are present, and there is no dysplasia seen. Okay, so this is a classical case of sinonasal papilloma inverted variety, very commonly asked in your exam. Okay, and most of you that I have seen, you are not able to describe the slide properly. Okay, so this is the proper description. Okay, so classify the tumors arising from the nasal, paranasal and skull base. Okay, so they are divided under 4 main headings. Number 1 is the respiratory epithelial lesion. So under the heading you have subheadings like sinonasal papillomas, carcinomas and adenocarcinoma. Then you have hematomas, mesenchymal tumors like angiofibroma, then other tumors like meningioma. Now what are the new entities which are added in the current WHO 5th edition in this topic? So HPV related multiphenotypic sinonasal carcinoma, and other new entity is SWI/SNF complex deficient sinonasal carcinoma. Now classify the sinonasal papillomas and also state the most common site of origin of each. So the term Schneiderian papilloma, okay, it is no longer recommended by WHO 5th edition. Remember this point. Although many of the examiners might ask you what is Schneiderian papilloma, so you just say that, okay, it basically is sinonasal papilloma. There are 3 main types. This is this, and also state that currently the WHO is not recommending the use of this term. So the 3 main types of papilloma that we are having is sinonasal papilloma inverted variety, which is the most common variety, constituting 47 to 73% of all the sinonasal papilloma. So it is most commonly arising from the lateral nasal cavity wall and or paranasal sinuses, most commonly the ethmoid or maxillary. Second most common variety is your oncocytic variety of sinonasal papilloma, constituting 3 to 19% of all the sinonasal papilloma. And again, just like the sinonasal papilloma inverted variety, they are also arising from the lateral wall of the nasal cavity and or paranasal sinuses, most commonly the maxillary sinus. And the third and the rarest variety of sinonasal papilloma is the exophytic variety, which is very rare, and their location is also different. They are arising from the lower anterior nasal septum. Involvement of lateral nasal wall and paranasal sinus is very rare, and it is the least common variety also. Okay, remember this point. Next important question is discuss the classical histopathological features of all types of papilloma. So if you see the sinonasal papilloma inverted variety, we have already discussed. Okay, for the oncocytic variety, they are showing a mixed exophytic and endophytic tumor growth. Okay, comprising multiple layers of cuboidal to columnar cells with abundant amount of oncocytic cytoplasm, okay, with slightly enlarged and irregular but centrally placed nuclei and small nucleoli. Scattered admixed ciliated or mucous columnar cells may be present superficially. Intraepithelial neutrophilic inflammation is common, whereas microcyst with mucin and or neutrophilic microabscess, they are characteristic. Coming to the histopathological features of exophytic variety. So exophytic papillomas, as it is suggesting, they are exophytic lesions comprising of papillary fronds with fibrovascular cores covered by multi-layered squamous to ciliated pseudostratified columnar epithelium, that is 5 to 20 cells thick. Scattered mucocytes and intraepithelial neutrophils again common. So this is about the classical histopathological features of each variety of sinonasal papilloma. Then discuss the molecular genetics of sinonasal papilloma. So remember, The sinonasal papilloma inverted variety, they show somatic EGFR mutations involving exon 20, which is present in 88% of the inverted variety, leading to downstream activation of MAP kinase and PI3K AKT growth pathway. Secondly, you have the oncocytic variety. In the oncocytic variety, oncogenic mutations in KROS exon 2 or 3 is present, which is stimulating the growth via KROS activity and downstream activation of MAP kinase and PI3K AKT pathways. Now remember, the low risk HPV infection is associated only with the inverted variety and the exophytic variety. It is not associated with the oncocytic variety. And remember, malignant progression of inverted and oncocytic sinonasal papillomas to sinonasal carcinoma is associated with deleterious TP53 and CDKN2A mutation. Malignant transformation is very rare in the exophytic septi. So remember this point very carefully. Okay. So discuss the prognosis of sinonasal papilloma. Remember, it is a benign neoplasm, though it shows recurrence, and the recurrence rate is different for different types. For the inverted variety, the recurrence rate is 12 to 16%. For the oncocytic variety, the recurrence rate varies between 6 to 40%, and for exophytic variety, it is between 22 to 50%. Malignant transformation is also seen to non-keratinizing or keratinizing squamous cell carcinoma, and the range of malignant transformation rate for inverted variety is 2 to 4%. For oncocytic variety is 3 to 17%, and as I said, the malignant transformation is very rarely seen in the exophytic variety. Remember, cigarette smoke exposure is a risk factor for inverted sinonasal papilloma malignant progression, and recent evidence suggests that low risk HPV infection in inverted variety may be associated with an increased risk of malignant progression. So there are two important risks associated with malignant progression. One is cigarette smoke, another is low risk HPV infection. Now discuss the differential diagnosis of sinonasal papilloma. Now remember, for the inverted variety, the most important differential diagnosis is non-keratinizing squamous cell carcinoma. Both may demonstrate an endophytic growth pattern, but remember, the non-keratinizing variety frequently has a basaloid appearance. Secondly, conspicuous pleomorphism and or increased mitotic activity, atypical mitosis, predominantly exophytic growth. Okay, predominantly exophytic growth is there, but sometimes it can show predominantly endophytic pattern. And now they lack, as I told you, the papillomas, mostly all the varieties, they will show the presence of this mucus cells, and transmigrating neutrophilic inflammation can be seen. But remember, in case of cancers, okay, they show lack. Okay, cancers, they show lack of this transmigrating intraepithelial neutrophilic inflammation. Furthermore, although non-keratinizing squamous cell carcinoma is often positive for high risk HPV, the ISP or inverted variety of sinonasal papilloma, they are consistently negative for high risk HPV. Remember, oncocytic variety and your inverted variety, both of them are associated only with low risk HPV, as I have already stated. Okay, as I have already stated, remember this point. Okay, classically. Okay. Now the differential diagnosis of your exophytic variety, if you see, it must be distinguished from cutaneous keratinizing squamous papilloma. Okay, remember this point, which is much more common in the nasal vestibule. So remember one thing, the sinonasal papilloma, remember the inverted variety, remember the exophytic variety of squamous papilloma must be differentiated from the cutaneous keratinizing squamous papilloma. Remember, it is far more common in the nasal vestibule. This cutaneous keratinizing squamous papilloma, they are more common in the nasal vestibule. They are lacking any mucocytes and they lack any ciliated respiratory epithelium. They lack mucocytes and ciliated respiratory epithelium, and they may contain skin adnexa, but they lack seromucinous glands. Now remember, the exophytic variety, as we have already seen, okay, the exophytic variety, if you see, they are more common in the lower anterior nasal septum, and very importantly, they show a pseudostratified respiratory epithelium and scattered mucocytes, and your neutrophils, transmigrating neutrophilic inflammation is very common, which is not seen in case of cutaneous variety of squamous papilloma. So this is the most important differential diagnosis for the exophytic variety of sinonasal papilloma. And lastly, rhinosporidiosis. Now remember, endospores involving the submucosa may mimic microcysts seen in oncocytic papilloma. Okay, endospores are located within estroma rather than the epithelium, whereas all the Okay, so basically endospores are located within the stroma and not in the epithelium, whereas the microcysts, they are present inside the epithelium. Okay, so these are the three important differential diagnosis of different types of sinonasal papilloma. So with this we have completed the case 46. Now we go to case number 47. So what do you see? You see a 37-year female presenting with pelvic pain. So what do you see over here? You can see section shows presence of endometrial glands along with classical endometrial stroma in a ovarian, in a background of ovarian stroma. Okay, and at places it is not very commonly seen. You can see hemosiderin laden, you can see certain brownish hemosiderin laden macrophages. Yes, what is the case? It is the case of endometriosis. So section shows presence of endometrial glands and stroma embedded in ovarian stroma and presence of hemosiderin laden macrophages. So for diagnosis, remember at least two of the following should be present: presence of endometrial type glands, endometrial type estroma, evidence of chronic hemorrhage, which is presence of hemosiderin laden or foamy macrophages. Remember, endometriosis is a condition wherein you see the endometrial glands and stroma but outside the uterus. Okay, the condition is outside the uterus, and if you see inside the uterus, okay, for example in the myometrium, then the condition is called as adenomyosis. Okay, in rare cases you might only come across the stroma and you might not see the glands or evidence of chronic hemorrhage. In that case, other diagnoses must be considered. Okay, so remember these points very importantly. So what are the sites of endometriosis and what is the most common site? So the sites of endometriosis, okay, in descending order of frequency includes the ovaries, uterine ligaments, rectovaginal septum, cul-de-sac, pelvic peritoneum, serosa of large and small bowel, as well as appendix, mucosa of cervix, vagina, fallopian tubes, and laparotomy scars, and the most common site being the ovaries. Now, what are the typical histopathological features? We have already discussed. Now, what are the theories of endometriosis and what is the most common theory? So, the theories include regurgitation theory, benign metastasis theory, metaplastic theory, extrauterine stem or progenitor cell theory, and among them the most common is regurgitation theory. Now, how do you differentiate it from adenomyosis? Now, adenomyosis is defined as the presence of endometrial tissue within the uterine wall, that is within the myometrium. Adenomyosis remains in continuity with the endometrium, presumably signifying downgrowth of endometrial tissue into and between the smooth muscle fascicles of the myometrium. Adenomyosis occurs in up to 20% of the uterus. On microscopic examination, you can see irregular nest of endometrial stroma with or without glands are arranged within the myometrium. So the endometrial stroma is very important. Like endometriosis, the clinical symptoms of adenomyosis include menometorrhagia, that is irregular and heavy menses, colicky dysmenorrhea, dyspareunia, pelvic pain, particularly during the premenstrual period. Now name endometriosis related neoplasm. So an association between endometriosis and ovarian cancer of endometrioid type as well as clear cell types has been noted with an approximate threefold increase in women with endometriosis. In some instances, it has been shown that carcinomas harbor the same mutations as associated endometriosis in the same patient, strongly supporting a pathogenic role for these driver mutations in the development of both pre-malignant and malignant lesions. Now, what is the role of IHC markers in the diagnosis? Now, remember CD10 is positive in the endometrial stroma. ER, PR and PAX2 are often positive in the endometrial glands as well as the stroma. Now, discuss the molecular alterations which are seen in endometriosis. So, mutations in the tumor suppressor genes and oncogenes can be seen, such as in KROS, PIK3CA, PPP2R1A, ARID1A have been identified in the epithelial cells of deeply infiltrating endometriosis. It is possible that they contribute to the locally aggressive behavior of deeply infiltrating endometriosis. Studies suggest a common origin of abnormal endometriotic tissue and ovarian carcinomas in some cases. Okay. Now discuss the prognosis of endometriosis. Now the risk of development of malignant neoplasm is estimated at 1% for premenopausal women and up to 2.5% for postmenopausal women. Approx 75% of neoplasms complicating endometriosis arises within the ovary. The most common extraovarian site is erectovaginal septum. There is an increased risk of endometrioid carcinoma followed by clear cell carcinoma of the ovary. Okay. Other associated neoplasms include seromucinous neoplasm, mainly borderline, okay, endometrioid adenofibromas and borderline neoplasms, adenosarcomas and endometrial stromal sarcomas. So approximately 75% neoplasms complicating the endometriosis, they arise within the ovary, and these are the most important neoplasms which is arising: endometrioid variety of carcinoma as well as clear cell carcinoma of the ovary. Now women with carcinoma arising in endometriosis tend to be premenopausal, obese and with history of unopposed estrogen. Endometriosis associated carcinomas other than clear cell variety tends to be lower grade and stage than similar ovarian carcinoma without associated endometriosis. What are the different diagnoses or differential diagnosis of endometriosis? So adenomyosis, number one, we have already discussed. Endocervicosis. Now over here the glandular component is endocervical mucinous type. There is no endometrial stroma and no evidence of chronic hemorrhage. And endometrioid adenocarcinoma. Now remember, sometimes what might happen that an endometrioid adenocarcinoma from the endometrium might metastasize, okay, to the ovaries. So how do you differentiate between a prime? Now remember, endometrioid adenocarcinoma, they are having a more complex glandular growth, okay, and they are having much more amount of cytological atypia compared to this, okay, endometriosis, okay. So how do you differentiate endometrioid adenocarcinoma versus your endometriosis? Remember, endometrioid adenocarcinoma, okay, will show more complex glandular growth. Now a primary one can arise from endometrium itself, okay, or it might be a de novo endometrioid adenocarcinoma. So how do you differentiate from endometriosis? Endometrioid adenocarcinoma in the ovary, for example, they will have a complex glandular growth and they will show cytological atypia as compared to endometriosis. So this is how you differentiate between the two. So three important differential diagnoses: one is adenomyosis, one is endocervicosis and endometrioid adenocarcinoma. Case number 48. Okay, a 40-year male with a painless lump in flexor aspect of right arm. So what do you see over here? You can see a well encapsulated tumor, okay, which is basically a biphasic tumor showing two areas. One is a more cellular area, okay, and this cellular area you can see, and another one is a less cellular area. So if you look at the more cellular area, they are basically composed of monomorphic spindle shaped tumor cells arranged in short fascicles, okay, and these are basically having spindle shaped nucleus with pointed end, as you can appreciate over here. At places what you will see that there is a nuclear palisading at the periphery, okay, nuclear palisading at the periphery, and in between you can see cytoplasmic eosinophilic processes. So this is the classical verrucae bodies and this is the Antony A area, okay. Correspondingly, you can see the less cellular area, which is basically the background is giving a myxoid appearance. In the high power, the cells, if you see, they are less prominent and the cytoplasm is less conspicuous, and you can see hyalinized blood vessels. Also, you can see areas, okay, where there is collection of lipid laden macrophages. This is the Antony B area, okay, and you can see collagenized, stroma in the background as well. You can appreciate over here. It is a classical case of a schwannoma. So section shows well encapsulated tumor composed of cytologically bland spindle cells arranged in short fascicles showing biphasic areas, a cellular and a less cellular area in a variable proportion. Now the more cellular areas comprises monomorphic spindle shaped cells with poorly defined eosinophilic cytoplasm with pointed basophilic nuclei set in a variably collagenous stroma. These cells commonly show nuclear palisading and parallel arrays of such palisades with intervening eosinophilic cytoplasm, that is the cell processes called verrucae bodies. The less cellular areas are also composed of such cells, but the cytoplasm is inconspicuous and nuclear appears suspended in copious myxoid, often microcystic matrix, and there is presence of blood vessels with thick hyaline walls and collection of lipid laden histiocytes, as we have appreciated over here, okay. So if you look at the histopathological features, so conventional, we have already discussed in details. I'm just repeating. Conventional schwannomas is usually an encapsulated spindle cell tumor that is composed nearly of entirely of well differentiated Schwann cells. Classical or conventional schwannoma is a biphasic encapsulated neoplasm having two components. One is the Antony A, which is the more cellular, and Antony B, which is the less cellular myxoid area in variable proportion. So Antony A and Antony B, I am not repeating again, I have already discussed, okay. Just remember, normal mitotic figures are a common finding in benign schwannomas, especially in the cellular Antony A area, but it is exceptional for these to exceed 5/10 high power field. And remember, progressive degenerative changes, most often reflecting lesional duration, that is long standing schwannomas will show degenerative changes, and or basically any schwannoma which has been frequently traumatized. Okay, they are common in schwannoma. So any a long standing schwannoma or a traumatized schwannoma will show degenerative changes. What are these? These changes include initially focal, okay, include hyalinization, stromal hemorrhage, cystic change, calcification. The point at which such tumors become classified as ancient schwannoma is blood. So progressively, so a long standing schwannoma showing progressive degenerative changes is basically called as ancient schwannoma. So the examiner might very commonly ask you, what is a ancient schwannoma? So your answer should be any long standing schwannoma, or those which are basically subjected to trauma. Okay, they show progressive degenerative changes, and this is called as ancient schwannoma. Now, what is the differential diagnosis of schwannoma? Number one is leiomyoma and leiomyosarcoma. Basically, they may show, these are also basically smooth muscle neoplasms. Okay, so they may show palisading and extensive degenerative changes in the form of hyalinization, myxoid change, and ancient nuclear atypia, just like a long-standing schwannoma. But over here, the individual cells are also elongated with eosinophilic cytoplasm, but the ends are rounded. But in case of your schwannoma, the ends were pointed. The nuclear ends were pointed. Over here, it is rounded. Remember, schwannomas, they are S100 positive, but these leiomyoma and leiomyosarcoma, they are S100 negative. And because they are smooth muscle neoplasm, they are SMA as well as Desmin positive. Second important differential diagnosis is neurofibroma. So neurofibroma usually lacks the capsule which is present inside schwannomas. They are formed of spindle cells, but characteristically they have shredded carrot collagen, and they have show presence of mast cells. Okay, usually neurofibroma is hypocellular, showing myxoid areas without any hypercellular areas, unlike schwannomas, and they have a weaker S100 focal calretinine and very strong CD34 positivity in comparison to schwannomas. Then MPNST, that is a malignant peripheral nerve sheath tumor. Remember, they will show an infiltrative growth pattern, a high grade tumor showing hypercellularity, pleomorphic nucleus with a very high mitotic activity with areas of geographical necrosis. They can show divergent differentiation, and S100 positivity is usually patchy and negative, unlike your schwannomas where they are showing proper diffuse and strong S100 positivity. Now enumerate the tumors arising from peripheral nerve sheath. So you will have schwannomas, neurofibroma, perineurioma, granular cell tumor. These four you should remember. Okay, then you can remember dermal nerve sheath myxoma, MPNST, malignant melanomatic nerve sheath tumor, dermal nerve sheath myxoma, solitary circumscribed neuroma, benign triton tumor, hybrid nerve sheath tumor, etc. Now, what are the most common sites of schwannoma? Now, very importantly, the common sites of origin, they are the peripheral nerves, where in the skin and subcutaneous tissue of which region? Head and neck, and along the flexor surface of the extremities. Now, spinal, intradural, extramedullary variety of schwannomas are also common, and they are also common, with multiple paraspinal schwannomas being commonplace in neurofibromatosis type 2. Whereas the cranial nerve involvement is not uncommon, with cerebellopontine angle tumors arising from vestibular division of 8th cranial nerve encountered most often, and bilateral involvement being a definitional criteria of neurofibromatosis type 2. So neurofibromatosis type 2 associated schwannomas which are bilateral, they are originating from the 8th cranial nerve. Then spinal, intramedullary and CNS sites are very rare, as are those involving the viscera like the GI and the bone. So it can arise from the GI, bone, or intramedullary sites can be there. They are very rare sites. Okay, it can either arise from the cranial nerve, okay, as a part of your neurofibromatosis type 2, or sporadically they can arise from peripheral nerves in the skin and subcutaneous tissue of the head and neck region and flexor surface of the extremities. Now discuss the IHC, the role of IHC in diagnosis of schwannoma. So immunohistochemically, schwannomas, they show diffuse and strong S100 and SOX10 positivity, calretinine positivity, in contrast to neurofibroma, and basal lamina components such as laminin and type 4 collagen positivity is there. Those which are located in the GI tract often show Jaffa positivity, while those in retroperitoneum and mediastinum are very commonly keratin positive. The perineurial capsule of schwannomas, they show EMA positivity, and CD34 staining is weak. Discuss the HP features of schwannoma. We have already discussed in detail, so not going over there. Now, is there any hereditary association? If yes, also discuss the molecular genetics of schwannoma. Now remember, the great majority of cases, they occur sporadically, while a small percentage are associated with type 2 neurofibromatosis. Rare patients develop multiple peripherally located schwannomas, but other than those associated with coexistent vestibular schwannomas, these are not associated with neurofibromatosis. So there is one group of multiple schwannomas which is associated with type 2 neurofibromatosis, but there is another group also known as schwannomatosis which is associated with SMARCB1 or INI1 mutation, as well as inactivation of NF2, and which is sometimes familial. So this is another group of hereditary association that can be there, that is schwannomatosis. Another one is type 2 neurofibromatosis. By cytogenetic analysis, most schwannomas show either monosomy 10 or loss of 22q material where NF2 gene is located. Okay, mutation or inactivation of NF2 leads to loss of Merlin expression, thought to be a key event in schwannoma pathogenesis. So this can be seen basically in both sporadic as well as in case of familial varieties of schwannomas. But remember, the hereditary association most commonly is type 2 neurofibromatosis and schwannomatosis. And the ones which you see in schwannomatosis, they are not associated with neurofibromatosis. They are usually having association with SMARCB1 INI1 mutation as well as inactivation of NF2, but they are not associated with NF2 neurofibromatosis as a syndrome. Now enumerate the variants of schwannoma. What is ancient schwannoma? Ancient schwannoma, this essentially represents benign schwannoma in which there has been severe degenerative changes that we have already discussed about. And basically, what are the variants of schwannoma? We are having cellular schwannoma, plexiform schwannoma, epithelioid variety schwannoma, microcystic or reticular variety of schwannoma. Discuss the differential diagnosis of schwannoma, which we have already discussed, so we are not repeating again. Now discuss the prognosis of schwannoma. Do they show malignant transformation? So schwannomas, they are benign and they do not usually recur if treated by gross total resection. Cellular and plexiform examples are least amenable to total removal and sometimes can only be debulked. Malignant transformation of schwannoma is in contrast to neurofibroma. They are very rare. So malignant transformation is very rare in schwannoma, but undoubtedly it does occur. And interestingly, in most of these cases, the malignant component has exhibited epithelioid morphology. The very rare examples of schwannoma that undergoes malignant change most often show features of high grade epithelioid MPNST or distinctively epithelioid angiosarcoma. Okay, what is psamomatic melanotic schwannoma? It is a distinctive type of peripheral nerve sheath tumor that occurs as a component of Carney's complex. As I told you, usually schwannomas, they occur as a part of hereditary syndromes include type 2 neurofibromatosis and schwannomatosis. Also remember, okay, they can occur as a part of Carney complex. But over here, most of them, they arise from spinal nerve roots. As the name indicates, the tumor is characterized microscopically by presence of melanin pigmentation and deposition of psammoma bodies. In contrast to all other types of schwannoma described in this section, the psammomatous melanotic variety is regarded as a low-grade malignancy because of its tendency for local recurrence and ability to metastasize. So that is why we have discussed separately. Okay. Now case number 49. Let us see. You can see a 42-year male with a firm nodule over the dorsum of the tongue. So what you can see, we can see a poorly defined tumor mass which is basically showing a solid to you see a solid sheet of cells arranged in nest and trabeculae, and individual tumor cells you can see that they are showing, they are polygonal and they are comprising of voluminous, they are having voluminous eosinophilic granular cytoplasm, and the nucleus you can see they are central to peripheral with and they are small hyperchromatic with prominent nucleoli, as you can appreciate over here. And if you see, you can see the associated epithelium, they are showing pseudoepitheliomatous hyperplasia. So what is the diagnosis? It is a case of granular cell tumor. So section shows a poorly defined tumor composed of sheets of tumor cells which are arranged in nest and trabeculae within a fibrous stroma. Overlying epithelium shows pseudoepitheliomatous hyperplasia. Individual tumor cells, they are large, rounded, polygonal and have copious, finely granular eosinophilic cytoplasm. Cell borders at places are ill-defined. The tumor cell nuclei, they are small, central to eccentric and hyperchromatic. The tumor cells are